Welcome back to the deep dive. Okay, I want you to just think about the neck for a second. It's a cylinder, right? Maybe 4 or 5 inches across. But inside that tiny, tiny space, you've got the pipe for your air, the pipe for your food.
All the major plumbing.
Exactly. And the nerves for your voice, and then these massive arteries just pumping blood straight to your brain.
It is an unbelievably high-stakes piece of real estate. You've got the respiratory system, digestive, neurological, vascular, all crammed together.
It's an anatomical mineshield, and for a surgeon, we're talking millimeters. A tiny slip one way or the other, and you've taken out the airway or hit a vessel.
It's not a forgiving place to work.
Not at all. So today, to help us all navigate this minefield, we are cracking open a true classic. We're going deep into Chapter 52 of Baily and Love's Short Practice of Surgery. We're using the 28th edition.
A book that's seen the inside of a lot of call room lockers. The chapter is titled The Pharynx, Larynx, and Neck.
Which, sounds straightforward enough.
Deceptively simple.
It is. I've been through it, and it is dense. So let's be really clear about our mission here. We are not just going to read you the textbook.
No, please don't. You can do that on your own.
Our goal is to interpret it, to pull out the hooks, the things you can hang your knowledge on. We want this to be a ready reckoner, a revision tool.
Think of it like a guided tour. We'll point out the dangerous turns and the key landmarks so that when you do go and read the chapter, and you absolutely should, the diagrams alone are worth it. The information actually has a place to land.
Right. We're building the mental framework. So let's lay out the roadmap. We're going to travel downward, starting right behind the nose, down through the throat to the voice box.
Then we'll explore some of those mysterious lumps and bumps that showed up in the neck.
And we'll finish up with some pretty intense scenarios involving trauma and major surgery. So let's start with the basic geography. The book calls the pharynx a fibromuscular tube, which is...
accurate, but not very memorable. A bit dry.
Yeah, a bit dry.
I find it much easier to think of the pharynx as a 3-story building. The whole thing runs from the base of your skull all the way down to about the C6 vertebra where the cricoid cartilage is.
Okay, so a 3-story building. Walk me through the floors.
So the top floor, the penthouse suite, is the nasopharynx. It's tucked in right behind your nose, above the soft palate.
And it's just for air, right?
Just for air. It's pure respiratory territory.
Yeah.
Then you get in the elevator and go down to the ground floor. That's the oropharynx.
The part I see when I look in the mirror?
That's the one. It's the common area at the lobby.
Yeah.
It handles both air coming down and food coming in from the mouth. It's a shared space.
And the basement?
The basement is the hypopharynx. It sits behind and around the sides of the larynx, and it's basically the funnel that directs food down into the esophagus.
Penthouse, ground floor, basement, naso, oro, hypo. Okay, that clicks. Now, any important building like this needs security, and the book talks a lot about something called Waldeyer's ring.
It sounds very dramatic.
It does. It sounds like something out of Tolkien. But it's our first line of immune defense, isn't it?
It is. Waldeyer's ring is just a circle of lymphoid tissue that stands guard at the main entrance to your airway in your gut. Think of them as the bouncers at the club.
So who's on the security team?
You've got the adenoids on the roof up in the nasopharynx. You've got the palatine tonsils, the ones everyone knows about, guarding the side doors in the oropharynx.
Okay.
And then the lingual tonsils are on the floor at the very back of your tongue. Plus a few other smaller bits of tissue. They're all part of malt mucosa-associated lymphoid tissue.
Now, here's something the source material really highlights that I think is important. In kids, these tonsils and adenoids can get huge. And parents, they see these massive things in their kid's throat and they panic. But Baily and Love says this is normal.
It's not just normal, it's physiological. It's a sign that the system is working. Well, think about what a child's immune system is doing. It's seeing everything for the first time. Every cold virus, every bit of bacteria on a toy. Those security guards in Waldeyer's ring are working overtime.
They're learning the threats.
They're sampling everything, processing antigens, and basically training the rest of the immune system. So when they get big, when they hypertrophy, it just means they're busy doing their job.
Yeah.
It's a sign of a healthy, active immune response.
So the takeaway is don't rush to whip them out just because they look big.
Exactly. The only reason to take them out is if they're causing a real problem, like physically blocking the airway and causing sleep apnea, or making it hard to swallow. Otherwise, you just leave them alone.
And they shrink later on.
They do. They tend to regress around puberty once the immune system has built up its library of threats.
Great point. Okay, let's move from the tube to the valve. The larynx. Now, I think for most people, when you say larynx, they immediately think voice box.
They do. Singing, talking, communication.
But that's a huge misconception, isn't it? The book is pretty clear on this.
It's probably the biggest misconception we need to clear up. Evolutionarily speaking, making sound is just a happy accident. It's a bonus feature.
A bonus feature.
Absolutely. The larynx did not evolve so we could debate philosophy or sing opera. It evolved for one primary reason, to stop us from choking to death.
It's a sphincter.
It's a sphincter. It's the guardian of the airway. Its number one job is to slam shut when we swallow, to make sure food and drink go down the esophagus and not into the lungs. Voice is just something we learn to do with it along the way.
That reframes things completely. Now, inside that larynx, there's one structure the book flags as being critically important. Not the Adam's apple, but the cricoid cartilage.
The cricoid is the true anchor of the whole system. And its defining feature is that it's the only complete circumferential ring in the entire airway.
What do you mean by complete?
Well, if you look at the rings of the trachea, your windpipe, they're actually C-shaped. They have a soft, flexible bit at the back. But the cricoid is a solid 360-degree circle of cartilage. It's shaped like a signet ring.
And that complete ring design is what makes it so dangerous clinically.
It's exactly what makes it so dangerous, especially in kids. Because a complete ring can't expand. It's rigid.
Okay.
So in a small child, the narrowest part of the entire airway is the subglottis, the space inside that cricoid ring. Now, imagine you have a sick child and you need to put in a breathing tube.
An endotracheal tube.
Right. If that tube is even a tiny bit too big, or if you inflate the cuff too much, it presses against the inside of that rigid cricoid ring.
And the ring doesn't give?
The ring doesn't budge. All the pressure goes inwards. It squashes the delicate lining of the airway, cuts off the blood supply. Ischemia, then ulcers, then scarring and fibrosis, and you're left with subglottic stenosis, a permanent, rigid narrowing of the airway that is an absolute disaster to fix, all because that one ring is complete.
That's a fantastic and, frankly, terrifying anchor point.
Yeah.
Before we move on, let's just quickly touch on the lymph nodes. The text maps them out using a level system from I to Z. We don't need to memorize them all right now, but is there one level that's like a central station, a hot spot?
If you remember nothing else, remember level 2. These are the upper jugular nodes. They're right up high in the neck, along the sternocleidomastoid muscle.
And why there?
Because that's the primary drainage basin for almost everything important in the throat. The tonsils, the back of the tongue, the pharynx. If you have tonsillitis, they swell up. If you have throat cancer, that is almost always the first place it will show up as a lump.
Level 2 is the sentinel node.
It's the first stop on the line.
Okay, that's a great framework. We have our 3-story building, our security guards, and the unforgiving cricoid ring. Let's go back upstairs. Section 2, pathology in the nasopharynx and oropharynx.
Right, back to the penthouse. Let's start with those adenoids. We said they get big, but when they get too big, they cause a classic clinical picture. It's called adenoid feces.
The book has a pretty vector description. What does that actually look like?
So imagine a child who just cannot breathe through their nose.
Yeah.
It's completely blocked at the back by this massive tissue. They have no choice but to breathe through their mouth, 247.
A chronic mouth breather.
And over months and years, that actually changes how their face grows. They develop a long, narrow face, a high-arched palate. Their mouth is always hanging open. They can even have dental problems. It's a very characteristic look.
And it can lead to obstructive sleep apnea, OSA.
A major cause of it in children, yes.
Okay, let's talk tumors in the nasopharynx. The text sets up a classic differential diagnosis, an exam question waiting to happen for a young person with a blocked nose. Angiofibroma versus an antrachoanal polyp.
And you really, really need to know the difference before you go anywhere near it with an instrument.
Why is that?
Because one of them will bleed like you've hit an artery.
Yeah.
Let's start with that one. The angiofibroma. The name tells you everything you need to know.
Angio for vessel, fibroma for fibrous tissue.
Exactly. It's a benign tumor, but it's basically a tangled ball of blood vessels.
Yeah.
And the key demographic here is adolescent males. It almost exclusively happens in teenage boys.
So a teenage boy comes in with a blocked nose and what else?
Nosebleeds. And not just little ones. We're talking torrential, scary nosebleeds.
Yeah.
If you look in the nose and see a red, angry, vascular-looking mass in a teenage boy, the number one rule is do not biopsy it in the clinic.
What happens if you do?
You will have an uncontrollable hemorrhage on your hands. It needs proper imaging, usually an angiogram, and often embolization to cut off its blood supply before you attempt to remove it in the operating room.
Okay, so that's the dangerous one. How does that contrast with the antrachoanal polyp?
It's the complete opposite. It's also benign, but it's just an inflammatory polyp that starts in the maxillary sinus, the one in your cheek, and grows on a stalk down into the back of the nose and throat.
And what does it look like?
It's pale, it's grayish, it's avascular, so it doesn't have a big blood supply. It's often described as looking like a fleshy grape. It can block the nose, but it doesn't cause those massive bleeds.
Red bleeding teenage boy, angiofibroma, pale, grape-like polyp. Got it. Now let's talk about the big one, the really nasty one in the nasopharynx. Nasopharyngeal carcinoma, NPC.
This one is fascinating from an epidemiological standpoint.
It's called the Cantonese cancer. Why?
Because the incidence in southern China and parts of Southeast Asia is astronomically higher than anywhere else in the world. We're talking 30, 40, 50 times the rate you see in Europe or the US.
And the book points to a combination of factors, a kind of perfect storm.
It's a trifecta. First, there's a clear genetic susceptibility in that population. Second, there's a very strong link to a virus, the Epstein-Barr virus, or EBV.
The same one that causes mono.
The very same. We can actually measure the amount of EBV DNA in a patient's blood to screen for this cancer and to see if the treatment is working. It's a key tumor marker.
And the third factor is environmental.
Right. The classic association is a diet high in salted fish, especially when consumed from a young age. It's thought that the nitrosamines in the preservation process are carcinogenic.
What's really frightening about NPC, though, and the text really emphasizes this, is how it presents. It calls it silent.
It's treacherous. The nasopharynx itself is a fairly large open space. A tumor can grow to a pretty significant size back there before it causes any local symptoms, like a blocked nose or a nosebleed.
So the primary tumor is quiet. How does the patient finally show up?
Two main ways, and they're both indirect. The first is with a lump in the neck. The cancer has already spread to that level 2 lymph node we talked about.
So they present with a metastasis.
Often, yes. Or, and this is the absolute key clinical pearl you have to take away, they present with unilateral hearing loss.
Wait, what? Hearing loss from a throat cancer? That seems counterintuitive.
It does, but the anatomy makes perfect sense. The eustachian tube, the little channel that ventilates your middle ear and equalizes pressure, opens directly onto the side wall of the nasopharynx. If a tumor starts growing there, what's the first thing it's going to do? It's going to block the opening of that tube.
And fluid builds up in the ear.
Fluid builds up. You get what's called otitis media with effusion, or glue ear, but it's only on one side.
This sounds like a massive red flag.
It is one of the biggest red flags in our specialty. An adult, particularly from a high-risk population, who develops fluid in one ear for the first time with no other explanation.
You have to look in the throat.
You must examine the nasopharynx. And you are looking for a tumor in a very specific spot. It's a little anatomical nook called the fossa of Rosenmüller.
The fossa of Rosenmüller.
It's a little slit-like depression just behind the opening of the eustachian tube. It's the classic hiding spot for these cancers.
I want to pause here for our first check-in question because this is so important. So if a patient presents to you with a new lump in their neck and fluid in just one ear, where is the first place you absolutely must look?
The nasopharynx, specifically that fossa of Rosenmüller. You're looking for a primary carcinoma that's blocking the eustachian tube. If you didn't get that, rewind the last 2 minutes and listen again. It could save a life.
Absolutely. Okay, let's drop down to the ground floor, the oropharynx, tonsils. Tonsillectomy is still a hugely common operation, but the text points out a specific danger zone.
It does. It's not as simple as just sucker them out. When you're removing the tonsil, you're dissecting it off the muscle of the throat wall, and just lateral to the tonsil, running down from the palate, is the paratonsillar vein.
And if you hit that,
that's the source of a lot of those scary postoperative bleeds. The ones where the patient is back on the ward and suddenly starts coughing up blood. But it gets even more serious.
How so?
A little deeper and more lateral to that vein is the big one. The internal carotid artery.
Wow.
And in some people, the artery can be tortuous. It can have a weird loop or kink that brings it incredibly close to the back of the tonsil, millimeters away.
You're taking out a tonsil and the main blood supply to the brain is right there. That's sobering.
It is. You have to respect the anatomy.
Now, speaking of the oropharynx, the whole landscape of cancer here is changing dramatically. It used to be a disease of old guys who smoked and drank their whole lives.
That was the classic patient profile, absolutely. But over the last 20 years, the demographic has been completely rewritten.
How?
We are now seeing an epidemic of oropharyngeal cancers, especially of the tonsil and the base of the tongue, in much younger patients. People in their 40s and 50s. Non-smokers, non-drinkers, otherwise fit and healthy.
And the cause is a virus.
It is. It's human papillomavirus,
Yeah.
HPV, specifically HPV-16, the same strain that's famous for causing cervical cancer.
So it's a sexually transmitted virus causing throat cancer potentially decades later.
Exactly. And the good news, if there is any, is that these HPV-positive cancers have a much, much better prognosis. They respond incredibly well to treatment.
But that creates its own set of problems, doesn't it?
It creates a major ethical and clinical dilemma, which we'll come back to. If you have a 45-year-old who you're going to cure and they're going to live for another 40 years, you have to be really, really careful about the long-term side effects of the treatment you give them.
It's a huge shift in thinking. Let's move to Section 3 and make this more concrete with a case study. I want you to picture this. A 25-year-old comes into the ER. They look sick, really sick. They've had a sore throat for 5 days, but now they can barely open their mouth.
Trismus. That's a huge sign.
And when they try to talk, their voice is muffled and strange. The book calls it a hot potato voice.
It's a perfect description. It sounds exactly like someone trying to talk with a mouthful of hot food because there's a massive painful swelling in the back of their throat.
So my alarm bells are ringing for an abscess, a collection of pus.
Immediately.
But the text makes a critical distinction between a quinsy, which is a paratonsillar abscess, and a parapharyngeal abscess. One is bad, the other is a potential catastrophe. How do I tell them apart just by looking?
Okay, this is all about the physical exam. It's about where the swelling is. With a quinsy, the pus is trapped right next to the tonsil, between the tonsil and the throat muscle. So the swelling is usually most prominent above the tonsil.
Okay, above the tonsil.
It pushes the soft palate forward, and it shoves the tonsil itself downwards and towards the midline. But the absolute classic textbook sign is what it does to the uvula.
The little punching bag thing in the middle.
That's the one. The swelling on one side is so big that it pushes the uvula all the way over to the opposite side. If you see uvular deviation, you're almost certainly looking at a quinsy.
Okay, so that's quinsy. What does the parapharyngeal abscess look like?
That's a much deeper infection. The pus isn't next to the tonsil. It's in the deep space of the neck, outside the throat muscles. So what you see in the mouth is the entire side wall of the pharynx, including the tonsil, being pushed straight towards the middle.
Like the whole wall is bulging inwards.
Exactly. But you don't usually get that same dramatic swelling of the soft palate or that classic uvula deviation. The swelling might also be more obvious from the outside, a big lump under the angle of the jaw.
And why is the parapharyngeal one so much more dangerous?
Location, location, location. The parapharyngeal space is often called the danger space of the neck for a reason. It contains the carotid sheath.
The carotid artery, jugular vein, major nerves.
All of it. An infection there can erode into the carotid artery and cause a fatal hemorrhage. It can cause a septic clot in the jugular vein. And it can track straight down the neck into your chest and cause mediastinitis. It's a true surgical emergency.
Which means the management has to be different.
Completely different. A quinsy, you can usually drain right there in the ER. You numb it up and stick a needle or a scalpel into it through the mouth. A parapharyngeal abscess? No way. You get a CT scan immediately to see exactly where the pus is in relation to those great vessels, and it almost always needs to be drained externally through a big incision in the neck.
You don't go poking around in the dark back there.
You absolutely do not.
Okay, let's head down to the basement. Section 4. The hypopharynx and larynx. The text calls hypopharyngeal tumors the silent killers. That word silent is back again.
It is, and for a similar reason as the nasopharynx, it's all about space. The hypopharynx contains these two pockets on either side of the larynx called the piriform fossa.
Piriform fossa.
They're like little side gutters that food slides down on its way to the esophagus. And they're quite roomy. A tumor can start growing in there and get really big before it causes any symptoms.
So by the time you have trouble swallowing,
It's often already quite advanced and has likely spread to the lymph nodes in the neck.
there's a specific cancer mentioned here, post-cricoid carcinoma, which is a bit of an outlier.
It is. Most head and neck cancers are far more common in men. But this one, a cancer right at the very entrance to the esophagus, has a notably higher incidence in women.
And there's a classic association.
A very classic, although now quite rare, association with Plummer-Vinson syndrome.
That's the triad of symptoms.
Yes. Iron deficiency anemia, esophageal webs which cause difficulty swallowing, and a sore, inflamed tongue, or glossitis. A classic for exams.
Okay, let's move into the larynx proper. For cancer of the vocal cords themselves, what is the one single symptom that the book basically puts in a big red warning box?
Hoarseness. a hoarse voice. The guidance is unequivocal. Any patient who is hoarse for more than 3 to 4 weeks needs an urgent referral to an ENT specialist for a look at their vocal cords.
You can't just write it off as laryngitis.
You cannot. It has to be investigated.
And the risk factors are no surprise. It's the classic duo.
Smoking and alcohol. And it's really important people understand that their effect isn't additive. It's synergistic. It's multiplicative.
What do you mean?
So smoking increases your risk. Drinking increases your risk. But if you do both, your risk isn't just A plus B. It's more like A times B. The theory is that the alcohol acts as a solvent, stripping the protective lining of the throat and allowing the carcinogens from the tobacco smoke to penetrate deeper and cause more damage.
That's a powerful visual. Let's talk treatment, because the book makes it clear this has changed a lot. The old way of dealing with laryngeal cancer was a total laryngectomy. Just take the whole voice box out.
For a long time, that was the only real option. And for very advanced cancers, or for cancer that comes back after radiation, it's still the definitive life-saving surgery.
Yeah.
But we have to stop and appreciate just how life-altering that operation is.
You're permanently separating the airway from the foodway.
You are. The top of the trachea, the windpipe, is brought out and stitched to the skin of the neck. It's called a permanent stoma. That's how you breathe for the rest of your life.
Through a hole in your neck.
Yes. Which means the air you breathe is no longer warmed or filtered or humidified by your nose. You can't blow your nose. You often can't smell things properly because there's no air moving through your nasal cavity.
And the book mentions they can't bear down.
Right. Think about lifting something heavy or even just straining to go to the toilet. What do? You take a deep breath and you close your vocal cords. The Valsalva maneuver. That builds pressure. A laryngectomy patient can't do that. They've lost that ability. It's a profound change.
Which explains the huge push for organ preservation.
Yeah, absolutely. The whole field has shifted. We now try to use very precise, high-dose radiation, often combined with chemotherapy, to kill the cancer while leaving the larynx in place.
Or smaller surgeries.
Or, for earlier stage tumors, we can go in through the mouth with a laser or a robot and just carve out the tumor itself, leaving the rest of the voice box intact. We will fight tooth and nail to save the larynx if we can.
Okay, before we leave the larynx, we have to cover the ultimate emergency. The airway you have to make right now, the cricothyroidotomy.
The slash airway. This is the can't intubate, can't ventilate scenario. The patient is turning blue, you can't get a tube in from above, and you have seconds to act.
The book is very clear on the landmarks. How do you find the spot?
You have to find the cricothyroid membrane. So you tip the patient's head back to extend the neck. You put your finger on the most prominent part of the thyroid cartilage, the Adam's apple.
Got it.
You slide your finger straight down the midline from there. You'll feel it drop into a little soft-spotted dip. That's the membrane. And right below that dip, you'll feel the next hard lump, which is that cricoid ring we talked about.
So you aim for the dip.
You aim for the dip. You make a horizontal cut through the skin and straight through that membrane into the airway.
What are the risks? What can you hit?
The membrane itself is pretty safe and avascular. There's a small cricothyroid artery that sometimes runs across the top of it, so you try to stay in the lower part. And occasionally a little extra piece of the thyroid gland, the pyramidal lobe, can be in the way. But in that situation, a little bleeding doesn't matter. Getting air in is all that matters.
Airway is non-negotiable. Okay, let's move on. Section 5, lumps in the neck. This is classic clinical stuff. And Baily and Love gives us a fantastic, if slightly terrifying, rule of thumb. The rule of 80s.
I love this rule. It's so useful for sharpening your thinking when an adult walks in with a neck lump. It goes like this. For a new non-thyroid lump in an adult, 80% are neoplastic, meaning a tumor.
Okay. Not just an infection.
80% of those are malignant, meaning cancer.
Wow.
And 80% of those are metastatic squamous cell carcinoma from somewhere else in the head neck.
That's an incredible statistic. It basically tells you to assume it's cancer until you've proven it isn't.
That is precisely the point. It stops you from just saying, oh, it's a swollen gland and sending them away. It forces you to go hunting for the primary tumor in the tongue, in the tonsil, in that fossa of Rosenmiller. You don't biopsy the lump first, you find the source.
Right. But in younger people and children, the odds are different. We're thinking more about congenital cysts, and the book gives us some really nice clinical anchors to tell them apart. So let's do a quick diagnostic quiz. I'll give you the finding, you give me the diagnosis.
Sounds good. Let's do it.
Okay, scenario 1. A young patient has a lump right in the dead center of their neck. I ask them to stick their tongue out, and the lump moves up.
That is a thyroglossal duct cyst, pathognomonic.
And why does it move with the tongue?
It's all embryology. The thyroid gland doesn't start in the neck. It starts at the very back of the tongue at a spot called the foramen caecum, and then it travels down to its final position. The cyst is just a piece of that pathway, that duct, that never disappeared. And since it's still attached to the base of the tongue, when the tongue moves up, it pulls the cyst up with it.
And surgically, you can't just cut out the cyst.
Absolutely not. It will just come back. The standard of care is cyst trunks operation. You have to remove the cyst, the entire tract leading up to the tongue, and this is the key bit, the central part of the hyoid bone, because the tract is intimately wrapped around it.
You have to take the bone.
You have to take the bone.
Okay, scenario 2. A lump on the side of the neck, kind of tucked in under the big SCM muscle. We put a needle in it, and we get this turbid fluid that shines with cholesterol crystals.
That's a branchial cleft cyst. It's another embryological remnant, basically a leftover from our developmental gill slit stage. The fluid inside is often mistaken for pus, but it's typically sterile breakdown products and shimmering cholesterol.
Scenario 3. A baby has a soft, mushy, multi-lobed swelling in the neck, maybe extending into the armpit. And when we take them into a dark room and shine a pen torch on it, the whole thing glows. It transilluminates brilliantly.
Cystic hygroma, no doubt. It's a malformation of the lymphatic system, a big collection of abnormal lymph channels. And because it's filled with clear lymph fluid, light passes right through it, which is why it transilluminates so well.
Last one. Another midline lump. But this time when the patient sticks their tongue out, it doesn't move at all.
Okay, so that immediately makes you think it's not a thyroglossal cyst. It's much more likely to be a dermoid cyst. This is just a little pocket of skin elements that got trapped under the surface during development. It has no connection to the tongue, so it stays put.
Great. One last tumor before we move on. A rare but very cool one. The carotid body tumor.
Ah, yes, the chemonictoma or paraganglioma. It grows from the little cluster of chemoreceptor cells that sit right in the fork of the carotid artery.
The cells that sense oxygen levels.
Exactly. And the book gives a beautiful, specific physical sign for this.
What is it?
Because the tumor is basically fused to the artery, it's pulsatile. You can feel a pulse in it. But here's the trick. You can gently rock it from side to side, horizontally.
Okay.
But you cannot move it up and down, vertically. It's fixed in that direction because it's tethered by the artery itself.
Mobile side to side, but not up and down.
That's the sign. And there's a classification, the Chamblin classification, that basically just describes how stuck it is to the vessels, which tells the surgeon how difficult and dangerous the operation is going to be.
A Chamblin type 3 sounds like a bad day at the office.
Now, type 3 completely encases both the internal and external carotids. Getting it off might mean you have to cut out a section of the main artery to the brain and reconstruct it. It's major high-risk surgery.
Okay, section 6. We're on the home stretch. Trauma, infection, and dissection. If someone suffers a penetrating injury to the neck, like a stab wound, the surgeons divide the neck into 3 zones. Why?
It's all about surgical access. It tells you how hard it's going to be to get to the injury and control the bleeding. Zone 1 is the base of the neck, from the collarbones up to the cricoid.
That sounds bad.
It's the worst, because the great vessels, the subclavian artery, the brachiocephalic, are disappearing down into the chest. To control them, you might have to split the sternum. High mortality.
Okay, what about the middle?
Zone 2 is from the cricoid up to the angle of the jaw. That's the best place to get stabbed, if you have to choose. Everything is right there, accessible. You can make an incision, see what you're doing.
And zone 3 is the top.
Angle of the jaw up to the base of the skull. This is a nightmare again, because the carotid artery and jugular vein are vanishing into bony canals in the skull. You have no proximal control. It's very difficult territory.
Let's talk about one specific infection with a name that sounds like a heart attack. Ludwig's angina.
Yes, the angina part doesn't mean chest pain. It's from the Greek for strangling or choking, which is exactly what it does.
So what is it?
It's a severe, rapidly spreading bacterial infection. A cellulitis of the floor of the mouth and the spaces under the jaw.
And clinically, what does it feel like?
The word the book uses is brawny. The whole area under your chin becomes rock-hard, board-like. It's not a soft, squishy abscess. And this woody inflammation in the floor of the mouth swells up so much that it pushes the tongue upwards and backwards.
And the tongue blocks the airway.
The tongue blocks the airway. That's the emergency. The cause is almost always an infection from a lower molar tooth that is eroded through the bone. It's an airway emergency first and foremost.
Finally, let's touch on the menu of neck dissections. This feels like a good summary of how surgery has evolved. We used to be, well, brutal.
We were. The original operation, the radical neck dissection described by George Cryle, was based on the idea that you had to remove everything in one big block.
What's everything?
All the lymph node levels, I through V, But also you took three major non-lymphatic structures: the big sternocleidomastoid muscle, the internal jugular vein, and the spinal accessory nerve.
Okay, losing a muscle and vein is one thing, but that nerve sounds important.
It's critical. The accessory nerve, cranial nerve equi, is what powers the trapezius muscle.
The big shoulder muscle.
Yes. When you sacrifice that nerve, the patient develops a shoulder drop. The shoulder sags, they can't lift their arm above about 90 degrees, and they often have chronic, debilitating pain.
So we realized we could probably be a bit more selective.
Exactly. We learned that the cancer doesn't always invade those structures, so we developed the modified radical neck dissection. You still take out all the nodes, but you make a concerted effort to preserve at least one of those other structures, most importantly, the accessory nerve.
And now we're even more refined.
Now, we do selective neck dissections. We've mapped the lymphatic drainage patterns. We know that a tongue cancer is most likely to go to levels 1, 2, and 3, so we just remove those levels and leave the rest of the neck alone. It's all about finding that balance between curing the cancer and preserving the patient's quality of life.
That is the perfect segue to our final thought. We mentioned it earlier, this huge shift from smoking-related cancers to HPV-related cancers. The book hints at this, but it's really changing the entire philosophy of treatment.
It's the biggest conversation happening in head and neck oncology right now. For 50 years, we perfected these huge aggressive operations, the radical dissection, the laryngectomy, to treat older patients with very aggressive cancers caused by smoking. The disability was profound, but the alternative was dying from the cancer.
But now the patient is different.
Now the patient is a 45-year-old, otherwise healthy, with an HPV-driven cancer that we know responds beautifully to treatment. So the question becomes, are we over-treating them? Do they really need the full scorched earth dose of radiation that we'd give a lifelong smoker?
The goal now is de-intensification.
That's the word. Can we give less radiation? Can we do a smaller robotic surgery instead of a big open one? Can we achieve the same fantastic cure rates, but leave the patient with fewer long-term problems, like a dry mouth or difficulty swallowing? We're in the middle of figuring that out, but it's a paradigm shift towards preserving function.
Fascinating to see the science and the ethics evolving together. We have covered a huge amount of ground today.
We really have.
From the nasopharynx down to the larynx, Waldeyer's ring, the fossa of Rosenmiller, all those cysts and tumors.
It is a very, very dense chapter. But hopefully, if you use these anchors, the three-story building, the complete cricoid ring, the rule of 80s, it all starts to make a bit more sense.
Okay, before we sign off, here is your call to action. Go and open Chapter 52 in Baily and Love. I want you to find two specific images. First, find the diagram of the triangles of the neck. You just have to see it visually to understand it.
Absolutely.
And second, find the illustration that shows the path of the recurrent laryngeal nerve. When you see how intimately it's related to the thyroid gland, you'll immediately understand why thyroid surgery is such a delicate business.
And find a cross-sectional anatomy diagram. Seeing how all these structures are packed together is a really powerful image.
Keep learning, keep asking questions, and don't get overwhelmed by the anatomy. You can do this. Thanks for joining us for this deep dive.
Goodbye.